Hi everyone, I'm still talking about breast cancer. Today I'm going to talk about differential diagnosis and treatment. Okay. Hope you've listening to the first two presentations on breast cancer. That is breast cancer 1 and breast cancer 2. With that, you'll be able to flow very well and enjoy this. Let's go. What are the differential diagnoses here? Because it's not just any lump that could be carcinoma. Okay, any lump or mass is worthy of being reported to a doctor and investigated. It may be benign. When we say benign in medicine, we mean, okay, is less of a trouble. It's not likely going to take your life when it is benign. So when it is benign, what could it be? It could be further accumulation lipoma. Yeah, could be abscess, could be fibrocystic changes, could be fibroadenoma, fat necrosis, galactocyte, tuberculosis granuloma, mammary duct ectasia. But it could be malignant. In other words, okay, this is a serious matter. This could take your life. It's not that we're going to forget about treating the benign cases, but malignant cases will raise more concerns. So if it is malignant, if it is spreading fast, if possibility of metastasis is here or is even present, then we're in for a big job because it's going to cut this life short. So it could be ductal carcinoma in situ, majority will be non-palpable, and the treatment here will be lumpectomy, and we give tamoxifen. It could be lobular carcinoma in situ, which will be non-palpable, incidentally diagnosed through fine needle aspiration or incisional biopsy. It could be invasive ductal carcinoma or invasive lobular carcinoma. It could be Paget's disease, in which case the ductal carcinoma invades the nipple and then there's scaling and eczematic lesion. Could be inflammatory carcinoma with ductal carcinoma, invades lymphatic system, very aggressive, erythematous, edematous, warm, and tender. Of course, those are features of inflammation. There will be pulled range, indicating that this is an advanced disease. Now, you've seen something like orange there, right? It's going to appear like the orange will appear. I mean, there will be dimples, all those kind of stuff, as if you are looking at an orange, but not yellow like orange anyway. But it will be erythematous. Could be sarcomas and lymphomas. What are the favorable features? When it's less than 2 centimeters and low grade, and no lymph node is involved, or it is estrogen receptor positive or mucinous pattern, that would be great. When will it be unfavorable? when it is greater than 5 centimeters or it is high grade and lymph node is involved, estrogen receptor negative, inflammatory, and dermal lymphatics are involved, that is bad. Why? Because the chances of spreading to other parts of the body, which we call metastasis, is very high here. And with estrogen receptor negativity, it's going to be difficult to use tamoxifen to control it. And with the lymphatic involvement, the spread wide is possible. Like in my previous presentation, if you have gone over it, you'll be able to enjoy this better. Metastasis will be to the bone, to lungs, to liver, and to the brain. That's why when I was talking about diagnosis, I recommended CT scan of the head for bones, chest X-ray, can do CT of the X-ray of the abdomen of the pelvis as well, ultrasound for the liver, and bone scan for the bone. The treatment at this stage is hormonal therapy. If it is estrogen receptor positive, chemotherapy, and radiation. Somebody will ask, why not surgery? Something that has gone into the bone and you've detected that with a bone scan, or gone to the lungs and you've gotten that clearly with your chest CT or chest X-ray, or has gone to the liver and with your ultrasound or CT you pick that, or CT of the brain has revealed metastasis, or even clinical features is suggestive of metastasis, then are you going to cut all these organs away? You can. So once metastasis has occurred, then there is no need for surgery. So what we do is, if through the period of screening and diagnosis we could pick that this is estrogen receptor positive, then we give estrogen, receptor modulator here, like tamoxifen. And we give chemotherapy and radiation, but the prognosis is bad. When this is the stage, sorry to say, the individual will not have many years left. So the period of 36 to 60 months, now that's 5 years, 3 to 5 years. Sorry about that for those who are affected. It's painful to them, it's painful to their family members. The treatment here will be, first of all, let me define some terms before we start talking about details as per the treatment. When in the course of this presentation as per treatment, you hear was a mastectomy, that is surgical procedure for partial or complete removal of the breast. When you hear something like chemotherapy administration, that is the type of medication we give to kill cancer, chemotherapy. And of course, you must be familiar with radiotherapy. That is using ionizing radiation to kill or control cancer cells. Adjuvant therapy, that is after the first treatment, then when we want to prevent secondary tumor formation, we give that, and we call it adjuvant therapy. Neoadjuvant means we administer this medication before surgery. To do what? To shrink the tumor, to make it smaller. So with that, we can then go into details of the treatment. Treatment is team approach. A tree doesn't make a forest. No one doctor can handle the problems associated with breast cancer all by himself or by herself. Oncologists will be involved. Radiologists will not be left out. Pathologists will be invited. Surgeons will be consulted. General practitioners are in the middle of it. Nurses will help out. Social workers will be carried along. Geneticists will be invited. Physiotherapists will be consulted. And of course, psychologists will be needed. There must be a solemn gathering with the family members, or if the affected individual doesn't want the entire family members to be on ground, well, solemnly, the patient and the doctor will discuss the various ways to treat breast cancer and the possible complications or side effects of the interventions will be clearly stated. Vis-a-vis surgery, what will follow, the complications that will follow surgery, complications or side effects of chemotherapy, and side effects of radiotherapy, all will be discussed. The patients will then make a mind up on what kind of treatment to take. Nothing will be forced on you. You have your will, but the doctor will guide. Okay, stage 0. At this stage, we're going to do what we call breast conserving partial mastectomy with radiotherapy. Or it's possible to have breast conserving surgery alone if margins are greater than 1 centimeter and low nuclear grade. If it is estrogen receptor sensitive, we give Tamoxifen, and that is hormonal therapy. If woman epidermal growth factor receptor 2 positive, we give Trastuzumab. So HER2 positive, then there's a drug directly for that, Trastuzumab. And ER positive, Tamoxifen. If it is stage 1, we'll give breast conserving surgery. The axillary lymph node will be dissected and radiotherapy. Lymph node biopsy or mastectomy with node dissection could be done by choice of the patient. And tamoxifen could be added if it is ER positive, or Trastuzumab if it is HER2 positive after due explanation. Stage 2, breast conserving surgery with axillary lymph node dissection and radiotherapy or mastectomy with axillary lymph node dissection with tamoxifen if it is ER positive, and chemotherapy for postmenopausal women or postmenopausal women with estrogen receptor negative, you give chemotherapy. Stage 3. I hope you can understand the different characteristics of each stage based on my presentation on screening and diagnosis. So if you've not listened to that, please kindly pause, listen to that, and come back and follow up with this treatment. So at stage 3, we'll have what we call mastectomy plus axillary node dissection and chemotherapy. You can give neoadjuvant chemotherapy before surgery, and later you have radiotherapy. Adjuvant radiotherapy or chemotherapy after the surgery. So neoadjuvant before the surgery, then adjuvant radio or chemo after the surgery. At stage 4, because there's distal metastasis here, so no surgery. No surgery. Because you can't go and cut off the brain or cut off the bones or excise the lungs or pull off the liver. Those are the organs where the metastasis could have reached. So if that is the case, sorry, I empathize with the entire family and affected women. The only thing left is hormonal therapy, tamoxifen if it is estrogen receptor positive, and anastrozole if postmenopausal. And we can give our chemotherapy and radiotherapy and watch for what the fate will have. But according to our literature, they don't have long life anymore. Inflammatory, you can do radical mastectomy, which involves excision of pectoralis muscle as well. That is still done in some parts of the world, but not common in advanced countries anymore. So now, mastectomy plus axillary node dissection, which is a modified mastectomy, is now replacing radical mastectomy. You give radiotherapy, you give neoadjuvant chemotherapy before surgery. Okay, we want to talk briefly about chemotherapy and hormonal therapy. Tamoxifen, anastrozole, trastuzumab, paclitaxel, or ceftazidime if there is heart risk. Gemcitabine, paclitaxel, capecitabine if there is high glucose level or there's a problem like diagnosis of diabetes mellitus. Cyclophosphamide, daunorubicin or epirubicin, all these will be selected based on the individual and what has been picked on screening and diagnosis. So it's case by case kind of a stuff. It's not everybody that will just be unpicked and be given any type of medication. It will be specific based on what has been diagnosed. Etoposide, carboplatin, dexamethasone 30 mg a night before paclitaxel because there's possibility of severe allergic reaction if paclitaxel is given. So dexamethasone 20 mg will be given a night before. And there's always serious pain problem with breast cancer and any cancer for that matter. So opioids could be given, and if it is not so serious, NSAIDs could be given. But please, don't use that opioid beyond the prescription or the prescribed level. Okay, how do we follow up here? We are going to have physical examination done every 3 months for the next 2 years. Physical examination every 6 months for 2 years, and physical examination every 1 year after. So we are going to do endometrial biopsy in women if they are on tamoxifen. And the woman will ask, why bother my life again? Yeah, because you're on tamoxifen, you can come down with endometrial carcinoma. And we don't want that to happen, so we want to know on time. Psychotherapy is necessary because this is a very difficult situation for anyone diagnosed with, in fact, with any stage of the cancer, particularly those that require surgery, chemotherapy, and radiotherapy. Is a serious matter that could lead to depression and possible suicide. So, psychotherapists will be needed to talk them through this. Selection of combination of medications and radiotherapy, detail of that is beyond the scope of this presentation, but when the oncologists and the radiologists are all involved, appropriate selection will be made based on the stage of the cancer. We will end this series with the next presentation on complications of breast cancer. Thank you for following from the first presentation till this third one and awaiting the last one. I'm truly wishing all affected women well and the ability to cope with the possible interventions. Thank you.